Hello, class. I'm going to give you a quick lecture on acute inflammation. Acute inflammation is basically an initial response to tissue damage. It's a relatively non-specific response. The purpose is to eliminate dead tissue, protect against local infection, and allow the immune system access. There are 4 outcomes that can result from acute inflammation. The 4 outcomes are shown here on this slide. The ideal outcome is restitution. Restitution means that the damaged area has been replaced by organized tissue that was identical or is identical to the original tissue type. This results when the damaging agent has been removed and the destroyed cells regenerate. Another outcome shown going above or superior from the acute inflammation is fibrous repair. We sometimes think repair is what we want, but it's fibrous repair, meaning we're getting scar tissue. In this case, the cells cannot regrow and/or the tissue architecture has completely been destroyed, and we get a lot of collagenous fibrous connective tissue. Another outcome can be chronic inflammation, and that's discussed in another lecture. Basically, in chronic inflammation, we get a different set of immune cells, leukocytes, that invade the area. Lastly, going down from the acute inflammation box, we can get abscesses, ulcers, fistulas, sinuses, and I'll talk about that at the end of the lecture. Inflammation. Inflame means to set fire. Inflammation is a dynamic response of vascularized tissue to injury, which is basically what I said before. It is a protective response. The idea is to limit tissue destruction, isolate infection, and initiate healing. It basically is bringing defense and healing mechanisms to the site of injury. The etiologies of acute inflammation are our usual suspects, the ones that Dr. Minarsik first told us about at the beginning of the semester. They can be microbial infections, physical agents, things that might cause burns or trauma, even radiation, mechanical agents, chemicals, even immunologic reactions. The signs of inflammation are rubor, which means redness. That comes from the increased blood flow. Calor, which means heat, warmth. Again, that's from more blood flow to the site of injury. There's pain, duller, and this is going to be from chemical mediators that are signaling surrounding nerves. Along with pain is a loss of function. Functiolesa. Functiolesa basically means loss of function, and the idea is if you have acute inflammation and it hurts, it likely means that you're not going to keep using that area of your body. You're going to be more protective of it, and that's good. It means you're allowing it to heal. All too many times, I remember playing soccer in high school, and I would go in for a slide tackle, and I would sprain my ankle. Well, that's going to lead to inflammation. Rather than letting my ankle heal, I frequently would pop some ibuprofen and tell the coach, go put me back out. Put me back in the game, coach. And then the next day I would go to practice. I never really gave my ankle a chance to heal until it got so bad I just could not run on it anymore. That's the point of the pain and the loss of function. So you baby that area and you will allow the cells time to heal. The last one is tumor, swelling, and I'll talk about exudation in just a moment. The time course. For acute inflammation, this usually occurs in less than 48 hours. If the inflammation lasts more than 48 hours, It can lead into chronic inflammation and in some cases last for weeks, months, even years. The cell types that we see in acute inflammation are polymorphonuclear cells like neutrophils. In chronic inflammation, we see more mononuclear cells like macrophages, lymphocytes, like T cells, for example. How does it occur? Two main processes occur, and these main processes occur due to the release of chemical mediators that come from the exudate. That means fluid that comes from the blood plasma, but chemical mediators can also come from damaged cells. I will discuss these chemical mediators in just a moment. The two main phases are vascular and cellular. With the vascular phase, to sum up before I go into more detail, we'll see vasoconstriction followed by vasodilation. When we see vasodilation, we're going to see that this leads to more blood flow. But as there's more blood flow, we're going to see some of the plasma leaves the blood vessel, and the red blood cells that are left behind actually become more viscous. So ultimately, it will lead to stasis, less blood flow moving to that damaged area. And again, this loss of plasma from the blood vessel into the surrounding tissue means that there have been changes in the vascular permeability. And I'll talk about these changes that will occur and lead to the exudate. The cellular stage is all about the leukocytes, the polymorphonuclear cells, in particular neutrophils, leaving the blood vessel, going into the damaged tissue area, and then following chemical signals so that they can phagocytize any bacterial agents that might be there or damaged cells. So again, the mechanisms are vascular and then cellular. The vascular includes vasoconstriction, vasodilation, slowed blood flow because of the exudation, also known as edema. That's the tumor part. Cellular processes are going to include the processes for the cells to leave the blood vessel and then follow chemical signals to the site of damage. That's called chemotaxis. So let's focus on the vascular flow first. Vasoconstriction occurs first. That means arterioles with their tunica media are going to reduce the diameter of the blood vessel. Then there is an almost immediate vasodilation. As the vasodilation occurs, there is more blood to the site. But there will also be changes to the vasculature. The endothelial cells will start to pull away from each other in the capillaries. This will allow plasma proteins to leave the blood vessels and enter the tissues. And this will also mean that we're going to get plasma proteins like fibrinogen that go into the damaged tissue area and will help wall off that damaged area. And that's especially important if it happens to be a bacterial agent that caused this in the first place. As a result, the red blood cells that remain in the blood vessels will have increased viscosity, and this means the actual rate of flow of blood through those vessels will decrease. So let's review from a previous lecture why plasma fluid can leave a blood vessel. This is basically called filtration. And specifically, we're going to talk about this filtration that happens in tissue capillary beds. When this fluid leaves the blood vessel and enters the interstitial fluid, in excess, this is called edema. This fluid can either be a transudate or an exudate. I'm going to explain on this slide the difference between those two, the differences in the capillary permeability, and then on the next slide, I'll show you what those fluids look like. Transudate. We have actually had a lecture already where we learned about a transudate, but I didn't call it that. We had a lecture where we learned about body fluid compartments and third spacing. A transudate can occur in patients that have cirrhosis of the liver, a compromised liver, where they cannot make enough plasma proteins, and albumin is the most abundant plasma protein. Albumin is made by the liver. So if there is a decreased colloid osmotic pressure in the plasma, but the surrounding tissues still have their normal body milliosmolar of 300, the water will go towards the increased concentration of particles. We say particles suck. And this fluid that's leaving will be clear. And I'll show you a picture of this because there won't be a lot of protein loss. Exudates, however, we're going to see that the chemical mediators cause the endothelial cells to pull away from each other. And when that happens, there are more spaces, intracellular clefts between them. And this allows the fluid from the plasma to leave, but also a good amount of plasma proteins can also go with that fluid. And it's going to have a different color associated with it. So transudate, I like to think of it as translucent. It is primarily water with some ions and electrolytes, for example. Exudate, I think of exudate and I think of exit, meaning the proteins are exiting. And that is going to have a brownish color to it. Let me show you. So here are two test tubes. The one on the left has transudate. That would be the kind of fluid we would see in a person with cirrhosis of the liver. We talked about third spacing, would lead to the ascites. Ascites means edema in the peritoneal cavity. We can see this in children that have kwashiorkor, which means disease of the displaced child. Perhaps you remember your physiology class where you were talking about this case in your body fluid compartments where they are protein starved. They can't supply enough amino acids for the liver to make albumin, and they see a shifting. We see a shifting of the plasma fluid into the peritoneal cavity, just like we see with the alcoholic with cirrhosis of the liver. Now, exudate, we get a lot of protein that is coming along with the fluid. So the plasma proteins can leak out. We call this purulent exudate or pus. It brings with it fibrinogen, which will be important for clotting around the damaged tissue site, sort of to wall it off and have containment. It also is a byproduct of white blood cells that are breaking down themselves because of the phagocytic process, for example, or from breaking down the surrounding damaged tissue. So again, pus is an inflammatory exudate, rich in leukocytes, primarily neutrophils, and it also has parenchymal cell debris, meaning that it has damaged cell tissue. Now let's move on to the cellular response. The cellular response is going to basically involve leukocyte leaving exudation of the blood vessel. This is divided into 4 main steps. The link that you see on this slide is to a YouTube video that I will also include in our Canvas module. It's a short 4-minute video that highlights this entire lecture in a cartoon fashion. So this leukocyte immigration is going to be first led by margination, where the polymorphonuclear cells, the neutrophils, are rolling through the blood vessel and then they start to slow down because they are coming into contact with the blood vessel. This is called margination. So they're getting into contact, they're kind of rolling, and then the rolling stops because they have receptors that are adhering to proteins that the endothelial cells have inserted. These are called cellular adhesion molecules, or CAMs. I'll show you a picture of this in just a moment. Then they're going to have the actual immigration, diapedesis, where the white blood cells go through the intercellular clefts of the endothelium and enter the interstitial space. Then they're going to use chemotaxis, where they migrate through the interstitial space due to chemical signals from the damaged tissue cells. I will talk about the chemicals that are released. And then lastly, we're going to see these neutrophils phagocytize damaged cells, but also bacteria if they were present. So here's a little cartoon showing you the 4 steps that I just went through. We're going to see margination going along the endothelium. They roll for a bit. Then they have those CAM molecules, the cell adhesion molecules, that make them stop rolling. Then the actual diapedese, that means they're going to go in between those endothelial cells right there. And then they're going to be attracted to the chemicals released by the damaged tissues, shown right there, chemotaxis, and then phagocytosis. So here's one picture trying to show you all of that at once. Do not worry about all of the proteins that are listed here, but in the top left corner, we're seeing a leukocyte starting to move towards the endothelial lining of a capillary. It's rolling for a bit, and then we finally see, we can see it rolling right here. Then we see its adhesion molecules and receptors are starting to interact, which slows the rolling. And then there's diapedesis. It's going in between these endothelial cells shown here. Then there's chemotaxis, chemical signals that are released by the damaged tissue. I think of it almost like someone wearing perfume and it's attracting you to them. So these neutrophils are attracted to the chemokines. That means chemical signals that are being released. And it moves towards those chemokines, and then finally it will phagocytize the damaged tissue and possibly any microbes that might be there. Now, can this process be impaired or decreased? Sure. And sometimes we do this on purpose, especially if someone has tipped into chronic inflammation and we want to stop the infiltration of white blood cells to an area. So for example, steroids like corticosterone can affect margination and adhesion, just to give one example. The actual immigration, the diapedesis and being attracted to the chemotactic stimuli, there are drugs we can give, chemotaxis inhibitors, to prevent that. And then lastly, phagocytosis can be impaired. We learned in a previous lecture about chronic granulomatous disease, where the white blood cells, specifically neutrophils, lost their oxidative burst ability. So they could ingest the microbe, but they couldn't use their oxidative burst to actually destroy the microbe, and so it continues to live in them. Now, the chemical mediators that I've been talking about, they can be cell-derived or they can come from the plasma. The ones that are cell-derived, first of all, we have histamine. This can be released by mast cells and basophils primarily, but the short video that I'm going to have on Canvas also says from platelets. This will lead to vasodilation of upstream arterioles. Serotonin basically does the same similar function as histamine. And there are also prostaglandins that can be released, particularly from platelets. And prostaglandins like PGE2 can travel through the bloodstream and basically stimulate the brain and can lead to fever. And having an increased body temperature can actually be helpful if we're trying to kill off bacterial agents that cause the inflammation. So a slightly higher body temperature can be an advantage, and we talked about this in our thermoregulation lecture. But these prostaglandins can also stimulate nerve endings and cause pain. And remember, the pain with the functio laesa can actually be a helpful thing. Plasma-derived chemical mediators. These are usually released in precursor form, which means they need to be modified, usually cleaved in some way, to activate them. There are kinins, specifically bradykinins. Again, these can stimulate nerve endings and it leads to the perception of pain. Towards the end of the semester, you will have a lecture on pain pathways and learn more about that. We get fibrinogen, one of the plasma proteins that can leak through the increased intercellular clefts between endothelial cells. Fibrinogen, when activated, will actually create the fibers associated with a clot. And then if you remember your microbiology, the complement system, which we won't go through that again, augments the chemotaxis and phagocytosis that we saw towards the end of this process. To go back to our second slide, I just want to remind you that acute inflammation can have one of 4 outcomes. There's restitution, and that's when the damaged tissue is allowed to repair and it goes back to its original form. That is the primary ideal outcome. Sometimes we can get abscess formation where we have this area of damage that's been walled off maybe a little bit too much, and we are still getting some white blood cells attacking a certain area. There are different kinds of abscesses. I'll show you a picture of one in just a moment. And then we can have repair, which means it's not really the ideal outcome, but the area is basically replaced with collagenous scar tissue. And then lastly, of course, it can lead into chronic inflammation, which is absolutely not an ideal outcome. Our last slide, here is a picture of an abscess. And for those of you who might enjoy a good video or two from Dr. Pimple Popper, Sandra Lee, MD, I'm sure you've heard of her. It's always quite fun when she goes after the various types of abscesses. And this is basically a localized collection of pus. It's associated with tissue destruction and swelling, right? It's inflammation. There's a walling off. Oftentimes, Dr. Pimple Popper has to anesthetize the patient, and then you see her cutting into the tissue so that she can get into that walled off area and push out the pus. Sometimes it's more fluid-like, and other times it's more hardened, and that's kind of cool. There are other kinds of abscesses. They have different names like carbuncles, furuncles, which are boils. Anyway, if you haven't watched any of her videos, you can get quite lost in all of them. I find them fascinating. So I hope you enjoyed our short discussion on acute inflammation.